Hello, everyone. Welcome and thank you for joining the 15th webinar in our Pandemics and Society series. Today's topic is H5N1, Protecting High-Risk Communities. Today, we will be discussing H5N1 and the impact of its spread to high-risk farm workers who have been at an increased risk of infection. I'll now pass it to our moderator today, Jennifer Nuzzo, Director of the Pandemic Center and a Professor of Epidemiology, to begin today's conversation. Dr. Nuzzo?
Hello, all, and welcome to our discussion. So in the last several months, concerns about the public health threat posed by H5N1 have increased. And while this virus has been spreading in the wild for many, many years, in 2024, the spread seen for the first time on cattle farms and to farm workers have really kind of increased our concerns about this virus. And since early this year, we've been seeing farm workers becoming infected. And although these cases have so far largely been mild, severe illness is still a possibility. And so many have been arguing that there's an urgent need to protect farm workers from the worst this virus has to offer. But there has been little discussion about how we can increase farm workers' access to life-saving tools such as vaccines, tests, and treatments. So this webinar will discuss H5N1 and high-risk communities such as farm workers. We're going to talk about severity and what strategies we should be using to protect the health and safety of these high-risk groups. And to help us think about this topic, we're joined by two experts. We're going to hear from Rick Bright, who is the CEO and founder of Bright Global Health and former director of the Biomedical Advanced Research and Development Authority, or BARDA. He's an internationally recognized expert in biodefense, emergency preparedness and response, and vaccine, drug, diagnostic innovation and development. We'll also be hearing from Nahid Bhadalia. Dr. Bhadalia is the founding director of Boston University Center on Emerging Infectious Diseases. She also served as senior policy advisor for the global COVID-19 response for the White House and the interim testing coordinator for the White House monkey Mpox response team. So thank you for joining us today. And just before we start, I want to encourage that anyone who is listening, we will hope to have time for some Q&A. So please do use the Q&A function to place your questions, and we'll get to them later. We're going to turn to our panelists today. I'm going to take some moderator prerogative and start posing some questions. And we're hoping to have kind of a frank conversational discussion about this really important topic. So maybe I could start first with you, Nahid. So since 2024 started, we've now seen about 13 people that we know have been infected with H5N1. And as I mentioned, so far, fortunately, these cases have been mild. But sort of how do you think about what we've seen so far in the US in this year with kind of the totality of data that we have about H5N1? What does that mean? Are you reassured? How are you thinking about this?
Yeah, Jen, thanks so much. I think this question about what we perceive the severity of the virus is so critical because it kind of then determines, right, the public health response and how we organize that response and where we place it in the priority of threats that are out there. Generally, for most emerging infectious diseases, presentations fall along a 2 standard deviation, right? You might see people who have more milder responses and more severe. So that happens regardless. The way that I'm sort of looking at this, a question with the 13 the cases that we have had, majority of the presentations have been mild fatigue, conjunctivitis, one patient with the respiratory symptoms, but otherwise fatigue. And the question is, which of the different factors may be at play? And so in terms of differences and changes of severity, one, it could be just that we just haven't encountered enough people, right? We have a smaller number. The virus hasn't yet encountered of somebody who has medical conditions. We don't know enough about the demographics of the patients on farms, the patients who were infected. And so if it encounters somebody with more medical conditions, could they have a more severe presentation? So that's one thought. The other thought that I have is, could it be just a different population, right? You've had population differences in nutrition and, in other baseline immune functions. And so playing out differently, unclear. a few other more technical things is just the way that farm workers are getting infected. Routes of transmission and concentration of virus in terms of exposure may be different now than was encountered at some of the, the outbreaks on farms with birds. And so is this sort of, we know from ferret studies, for example, at least primarily and more studies needed, that there doesn't seem to be as much respiratory, ferret to ferret respiratory transmission with this particular H5N1 virus, but no human studies are available. No sort of active implementation science work has been done to look at transmission routes on the farms themselves. The other things are, has the virus changed, right? And that, I don't think there's enough data. If anything, there's data that sort of shows that there hasn't been adaptation, further adaptation to human salicylic acid receptors, the ones that the avian influenza viruses sort of use to connect. And then the last, of course, more important question in light of what we've seen in serological studies is, are we just missing people? Are we missing people who have milder disease? Are we missing people who may have more severe disease? And even in the past, when you look at the outbreaks in Hong Kong, and there were poultry workers and cullers who had like between 3 to 10% positivity, serological positivity, who were asymptomatic. And so there might be more cases we're missing them. There might be more severe cases we're also missing, maybe because people are not coming to care. And so it might be happening, or it may just not be diagnosed. So that's how I'm thinking about it. The one thing I will just end with is that I would not throw out the last 13 cases as saying this is how the virus is going to behave, particularly because the sample size is too small, but you're also talking about a virus that changes pretty fast, right? This is a very mutagenic virus that can change, particularly after it's had a lot of exposure among humans and ability to adapt to new species.
Yeah, so we don't know, and it's hard, I think, also to maybe reconcile it compared to the 20 plus years worth of data that we have on this virus that have shown very worrisome signs. So yeah, it is, I think there are a lot of questions that we still have. And while I think we're heartened by the mild nature of the cases, we don't obviously want somebody to get ill. I think it's hard to throw away worries from about this virus given past data. Rick, can I turn to you and talk about, maybe I'll just jump right in and talk about vaccine. This has been a very hard topic to kind of really wrap my head around in terms of where we are with H5N1 vaccines. We know that the US has been working on amassing a stockpile of vaccines for quite some time. You had responsibilities in that role, but sort of, can you just tell us kind of where we are with vaccines? And I know everybody is thinking about what do we have potentially to use today in high-risk communities? And then obviously there are questions about down the line where we need to vaccinate others. And that's not really on the table at the moment, but where are we? Can you just shine some light on this complex topic? We're hearing shifting stories.
No, it is. Thanks, Jen. Thanks for having me. It's such an honor to be here with you and Heed today. And as we were just hearing, this H5N1 virus is something we've known about and we've been studying for about 27 to 28 years. I would highlight that what's different this year is that it's in an unprecedented number of mammals. This is usually a bird virus. And now it's been in more mammals that are closer and closer to people. And so there is something different about the virus. And as a virologist, tracking its changes as it goes from host to host and mammal to mammal, and then surprisingly finding that it has this remarkable stability and sustainability in the cow population and now in cats and mice and others. So, it just warrants super close monitoring for any changes in this behavior in the animals and as more people are exposed. Going to the vaccines, there is no cut and dry answer. I understand why it can be confusing. It's as confusing probably as the nature of the virus itself. I mean, if we just had one virus like measles or something that rarely changed, you just had to have one vaccine and you just, made a bunch of that vaccine and stored it forever and ever, it could be an easy answer. But H5N1 and avian influenza viruses, we have a number that we've dealt with, H9s, N2s, H7, and a few others, but they're constantly changing. So as soon as we see that there is a potential pandemic threat or certain characteristics about a new avian flu virus, that we're tracking in animals and birds, or maybe infects a person or two, then we go through a risk assessment. And in that risk assessment, we determine if there is enough concern about that particular strain of H5N1, for example, to have the manufacturers, the vaccine manufacturers that have licensed seasonal influenza vaccine, should we have them go ahead and start with one of these new versions of avian influenza viruses so they can get some experience with it. We've learned that every single strain or version of influenza virus that we send to a well-established vaccine manufacturer behaves differently in the manufacturing process. And it behaves differently in the immune process as well. And so it's so important that we continue to get the manufacturer's experience, so we're not spending a lot of time guessing when that moment of urgent need comes to us. So those are these contracts we have with the US government and BARDA in particular, and the vaccine manufacturer with licensed flu vaccines. So every year, to warm base and keep those manufacturers warm and trained, we assign them a particular strain of H5N1, for example, to run through their system. Now, we get added bonus from this because they get the experience, but we get a little bit of vaccine for our stockpile. And that's just a batch, one single batch of that vaccine. Our goals and requirements for our, we don't call it the Strategic National Stockpile for Influenza, we call it the National Pandemic Influenza Vaccine Stockpile. Slightly different characteristic. One other nuance is, instead of holding all of these vaccine supplies for influenza in the Strategic National Stockpile storage, we keep all of these vaccines that for influenza at the manufacturer in their quality control systems in their facilities. So they maintain control of those so we can understand how they've been stored and how we can convert them quickly from a large container of bulk product into small vials and small syringes that we can use to administer the vaccine. So very complex history, but each of the manufacturers gets an order from the government each year. And the 4.8 million doses of vaccine that the US government is now describing being filled into vials from one manufacturer, CSL Seqirus, actually is the outcropping of one of those previous task orders. It was a 2020 virus, an H5N8 virus that showed some signs of concerns. It looked like a good example to warm up the manufacturers with that strain a couple of years ago. And so they started making that, and initial testing from the early production of that vaccine candidate from the manufacturers was tested in ferrets, and antibodies from ferrets that were vaccinated with this early dose of vaccine showed that the antibodies could likely cross-react and provide some benefit, maybe some neutralizing benefit for this new version of H5N1 that's circulating in the cows. And so the government made a decision, instead of taking that container at the company and just leaving it sit there for a while, why don't we go ahead and turn that into vials and syringes so we can have it ready to use. The vaccine itself, we know, as long as they keep it in those large vials, those large containers, I mean, it's pretty stable. We published papers and studies from the US government and our vaccine manufacturer partners showing that vaccine that's stored in those bulk containers could be stored for 10 years or longer, as long as it's in that bulk container. And then when we put it into that final container, like a vial or a syringe, we give it a 1-year shelf life. And that's just because traditionally, most seasonal influenza vaccines have a 1-year expiry date. We don't use them beyond a single year because the virus changes from season to season. And so I'm saying all this to probably give you this picture and how complicated it is to understand exactly how many doses we have. Every time you store those for a while, when you do put it in that final container, some of it degrades and you have to purify that out. So you don't always have as much as you think you do. And it takes a little bit of wastage when you put it in those final containers. But our requirement is to have 20 million doses of H5N1 vaccine or pre-pandemic vaccine in that stockpile at all times to be able to address the critical workforce And so people who we think will be most at risk and most essential to keep our government and economy and society running in the event of an influenza pandemic. So we always have those 20 million doses. However, it might be made up of different various types of H5N1 that we know would cross-react. I hope that that's not too
Yeah.
complicated.
No, it's really, really helpful.
That's why you can't get a straight answer always. They're not trying to be dodgy. There's just so many variables involved in that process. But the confidence you have in it is there's always some, and there's always some testing, at least to see if there's some level of cross-reactivity. And those manufacturers are always warm. We'll get to it later, but my biggest concern is how do we go from those, maybe 4 million doses we're talking about now, which can only vaccinate 0.7% of our population. How will we get to the 660 million doses we need just for the United States alone if we need it quickly? But that's later.
And then there's the global equity component of if this starts to become bigger, right? How do we share it?
So I'm going to pose a question to you both, and we've already started to talk ahead to a pandemic flu scenario. And that, just to be clear to anyone listening, we're not in that situation right now. The virus would have to change to become able to be more easily spread to people and between people. We don't have any evidence of that right now. But of course, as preparedness experts, we always think about the worst case scenario and what would we do if. But just kind of bringing it back to what we're worried about today, which is that we know that there is a virus that is causing outbreaks in cows on farms. And we know that workers and cows and birds, and we know that workers who have been exposed to these sick animals have gotten sick. And the question is, what do we do to protect those workers? So the question I want to pose to both of you is, if you were running the show, what would you be thinking about in terms of how to protect these workers? Would vaccine be something that you would be looking into now? And specifically, we're talking about vaccine that is for the virus that exists today, which is not the same as a pandemic virus that has yet to emerge. And Naheed, maybe I'll start with you.
Yeah, I think that CDC has done an incredible job, right? Trying to do engagement with and some of the states have really done a good job. Michigan and Colorado in particular come to mind, and recently in trying to reach a population. I mean, the issue here is you're seeing all these conflicting dimensions, right? Private farms, migrant workers, a group that maybe at baseline doesn't have access to care, and so it's sort of and on top of that, the whole balancing of state versus federal powers in terms of intervention in this scenario. Places where I think we can go much further, again, is trying to figure out how we move testing closer to those farm workers who may be working on this. One way that Michigan, for example, has taken this is doing testing on farms of workers who may have symptoms that have infected cows. Great start. My concern, though, is that there might be other farms where the virus may be spreading that we don't yet know about, right? And so how do we get ahead of, like, if we only focus on farms where there's known cow infections, I think we may miss potential other human infections, because it's my one like motto in infectious diseases is just that it's always later than you think during an outbreak. And so I kind of feel like that kind of, we miss those populations. So moving testing closer. I think a lot of work still needs to be done. You keep hearing reports about the fact that many farmers don't really know that H5N1 is or migrant workers in particular don't really know that this is a threat, and a lot more needs to be done to engage those communities, engage service providers that work with those communities to try to get the word out. And how you do that with sort of the balance of that and the commercial and private interests that are involved. In terms of vaccines, I know that there's an announcement to share the seasonal influenza vaccines with farm workers, which, as an infectious diseases physician, I will always support vaccination with seasonal influenza viruses. Get your flu vaccines, just as long as it's timed at a time that works, which is not right now. It would have to be probably October, because as we know, the seasonal flu vaccine, particularly in high-risk patients, as immunity wanes, you may be not protected at the end of the season. In terms of other vaccines, the way that I'm sort of thinking about it is, there are, as Rick said, right, there's work potentially to have a better match for this particular virus and to put those into an mRNA or other platform to produce that. So what about the vaccines that exist, dense cell-based vaccines that are there? Are they of any use currently? There's a lot of, conversation about, well, it's not very severe, and the virus doesn't seem to be transmitting human to human, so why do we do that? I think the framework that I use is laboratory workers. So I, for a very long period of time, was medical director for special pathogens unit at BU's biosafety level 4 lab, Needle. And the way that we approach vaccination in that setting with emerging pathogens is actually looking at the benefits to an individual who's working with these pathogens, right? Which is kind of occupational protection. And that's sort of the place where I'm coming at with this. And in those scenarios, often promising medical countermeasures are made available under an expanded access protocol or as part of a research study. And part of me does wonder whether that might be a way to then, to do that currently, to be able to explore the effectiveness of what we already have in our stockpile. Both, underlying concern with either this flu vaccine or use of any vaccine in the research setting. The concern, of course, would be you don't want people to feel like now they have complete protection and stop using other measures like personal protective equipment, right, or getting treatments. That's why education in all those scenarios and engagement is going to be so important. But I don't know what you think, Rick.
All great points. I'm really concerned about the farm workers, their families, and their communities. I mean, in this situation we are now with H5N1, with it being in the dairy cattle and some domestic animals and wild animals, our farm workers and their families are on the front line, and we have to think of them on the front line of this. They're the interface. There are canaries in the coal mine right now of when this virus changes, when it changes in animals, when it changes in people, and we won't know that it has gotten ugly until we see farm workers dying. And I think that is a horrible thing to sit back and wait. I think it's really, really important that we have honest communications with our farm workers, their families, and their communities about the risk of this virus. Not that it currently is mild in a few cases and some pink eye and et cetera, that it can turn deadly quickly, and it has, and they're on the front line. And therefore, I think with understanding that communication, we should be doing everything possible to protect them as people, protect them as fellow citizens, and protect them as our front line and bellwether for this outbreak, and our people we rely on for food on our table and things in our community. Maybe I'm extremely passionate because I'm from Kansas. I'm from a farm community, and I understand the commitment of people who work on the farms and their entire community, and many of the communities are really small. And so when I think about the potential benefit that we could make available to our farm families on the front line by offering a vaccine that we have already a lot of experience with, it's licensed, we know it's as safe as the seasonal flu vaccine that millions and hundreds of millions of people get every single year. It's not an exotic vaccine. It's not something new. It's not something experimental. And we know it provides protection. Actually, we know even when we have used vaccines for H5N1 made with traditionally licensed processes, even with influenza strains from 2003 and 4 and 5, and years later, when we had the same people in the clinical trial boosted with a different strain of H5N1 vaccine, we saw benefits still from even that unrelated early priming dose of vaccine. And so even if we had opportunity to have one dose of vaccine available or 2 doses of vaccine, even if it's not ideally matched, I think it would provide some level of protection in the farm workers and their families and community, and therefore would not wait to see how severe this virus got, but also would give them instead a layer of protection that would benefit them. So if the virus were to change, they would have protection from that severe illness and perhaps maybe death because they had some baseline immunity to H5N1. I'm a strong proponent of not mandatory vaccination. I'm not a proponent of mandatory vaccination, but we should make this available, and we should educate and communicate about the history and what we know about it, and the value and the potential it could have, and make sure that anyone who wants to get this vaccine, not people on a special checklist, not people who have to go through 10 levels of triage, anyone who wants to get this vaccine because they're concerned about exposure should be able to have access to it and get it for free.
Yeah, can I address a couple of questions that are in the Q&A, which I think are quite,
Can I just maybe summarize, just because this is so great, and then yes, address that. What I think I'm hearing from you both is support for use of vaccines offered, not mandated, offered to agricultural sector, farm workers, for the purposes of providing individual benefit, protecting these workers from the direct occupational hazard that this virus poses, with the hope of preventing, not just waiting for severe illnesses to occur, but preventing severe illnesses from occurring. So it's kind of this current approach of, well, it's been mild and maybe it will continue to be mild, risks that one day it may not be mild, and then we will have not missed an opportunity to prevent severe illness. I just want to make sure that that's what you both seem to be arguing for.
Yeah, I was going to say mine is maybe even narrower than that. I almost feel like it may even more maximum benefit identifying those who would be particularly high risk for severe illness, right? And making it available to those. We know who's at high risk a lot of times for influenza viruses in general, right? So there was a start off for that. And beyond that, like set up a mechanism where we can actually learn, about this. One of the things that I was blown away by just looking at the continuous data that's coming in, animal models are always helpful because they come first, right? But animal models only go so far. And if we want to understand a bit more about this virus, we really have to engage those who are at high risk, who potentially are getting infected with this, to be able to do greater understanding of the infections in humans. With Ebola patients, for example, we were able to do sort of serial viral concentration studies over time, understanding sort of the natural history of the virus in humans. I think involving vaccines, particularly made available through sort of expanded access, they're already approved. I totally get it. So maybe EAP is the wrong mechanism, but something that allows us to look at, getting some primary data in patients who may be A, be at risk, or two, may eventually get infected is going to be critical to the rest of our response. And I totally get some of the points that are in the chat. So two things so one point was about treatment, which of course, so critically important. So particularly if there's not going to be a vaccine update, we can't give up on the vaccine update just because we're saying we're going to concentrate on one. We can actually, walk and talk at the same time. We can do multiple things, which has always been responses. We got to do as much education on protection. We got to do as much early diagnostics as potential. The issue with only treatment approach is that it depends on somebody being diagnosed. And we've already talked about the fact that there isn't as much access. You could say, well, people can get flu tests. Yes, but are they? Availability is not the same thing as accessibility, right? The being able to sort of say, do this without fear in a space where it won't affect your employment. That's a really hard long-term conversation, which then includes to the second question that was put by Brandy, I think, saying, why are we, how do we engage these communities? The traditional lessons from every single time we've failed as a preparedness community of why communities don't engage with us is that we're very one disease focused, right? Whether it's Ebola, or there is H5N1 or Mpox, I think that the success stories, even with things like polio or Ebola and DRC, is always that you got to pay attention to the greater needs of that community. And in the migrant workers community, again, I think we need to take those lessons, not just for trusted messengers, but I think understanding the rest of the barriers to care that those communities face. It needs to require all those sort of baseline public health best practices that we already know.
And I'll just say, maybe to piggyback on that last point, reaching hard to reach groups is bread and butter public health. That's just what public health does. And it often means working with community-based partners that are trusted by the hard-to-reach groups, et cetera. But that's not unique to really any disease. That is a very common phenomenon in outbreaks. It is almost to be expected in outbreaks. And so that is like a core capacity of public health, which is to figure out how to do community engagement and often to work through proxy groups and trusted community-based partners. And I realize it's not easy, public health's not easy, but that's just what's something that public health does. Rick, I love your thoughts on sort of this kind of the treatment and testing based approach. In particular, there's been, I think one of the primary means of protecting farm workers right now has been post-exposure prophylaxis. So that is, you know that there's an outbreak on a farm, and then you offer prophylactic medicines to people who may have been exposed to a sick cow. Sort of, what are your thoughts on that in terms of its efficiency in protecting farm workers?
Well, you know, what I think is all about, I think it's a multi-layered approach. I think we should be talking about respiratory protection and PPE. I think we should be talking about testing and surveillance and pre-exposure prophylactic with antiviral drugs if they're in a culling procedure where they're going into a poultry house and they have big fans blowing and a lot of dead chickens are being cleaned up and culled. You know, that's a super high risk environment. And we should be doing everything possible to make sure those workers are fully protected. That could even be pre-exposure, real prophylactic use of antiviral drugs. And of course, I think that the vaccination is critical. You know, I don't think that the messaging and communication about the value of these, about the risk, is actually reaching the farmers and reaching the workers who are doing the culling and others. And I've talked to a lot of them. I hear from a lot of people reach out to me, and some of them still haven't heard of H5N1. Some of them certainly don't understand the value of testing, and they've had experiences with testing with COVID and, you know, without right medical care and coverage. And they've had workers or colleagues that have tested positive for COVID, then they're taken off the farm. They lose their job. They don't have medical health care coverage, and et cetera. And so there's this association that's been negative in some ways with testing for COVID. And so I think that just opens up the opportunity for improved communication about risk and about benefit. And so testing and surveillance isn't really to try to identify a person to move them out of the workforce. It really is to try to identify people who need treatment because of the risk that they can face if they are infected with this virus. It is the serology testing, which I know a lot of people don't quite understand. And it's complicated, and I can appreciate that, but it really is to look at the antibody levels to see who has been exposed to this virus. And, you know, it's probably had a mild illness, if any illness at all, but they were clearly exposed and have antibodies to it. And that can tell us a lot about the characteristics of an infection and even the potential for that human-to-human transmission that we aren't really fully getting a clear picture on because we don't have that sort of history of how the virus is transmitting from animal to people and people to people, et cetera. We're missing a lot of these data gaps that would be really informative to us to make sure that we have the right treatments and tools available for those at highest risk on the farm, and to make sure that we are developing the right tools as the virus might be shifting and changing, and to really just inform us on how concerned we should be about the outbreak and how it might be changing over time. So we should use every tool in the toolbox. We should make it freely available. In many cases, as Naheed said, on the vaccine, it'd be really great if we could set up clinical trial sites, not because we are concerned so much about the vaccine that's well established, but it will provide additional data, really important data to help us understand for this particular H5 vaccine, does it take 1 dose or does it take 2 doses? When it provides protective immunity, how long does that protective immunity last? We need another dose after a certain interval. And the antibodies would tell us as the virus changes, is the vaccine that we already had still effective, or do we need to update the vaccine? There's so many important things that we need to learn, but it really is a two-way conversation with the people who are at highest risk. And it takes a collaboration with the farmers and the communities, the scientists, and even the government workers who are trying to work together to put up a shield to prevent this virus from spreading and changing, protect the people at the highest risk, and also prevent a pandemic.
Yeah, one thing I wanted to just, beyond every other measure we've talked about beyond already, is remember how important and critical the environmental controls were during COVID, right? We've been talking about safer buildings and safer air, handling of air. I mean, this is another perfect example if you want to take a One Health approach to this, like in those spaces where, fans are blowing and right, that you were just talking about the scenario of human infections among the the poultry workers in Colorado. Like, we really need to step back to see how we can restructure the environmental spaces, right, that these workers are working on. Because absolutely PPE is important, but if it's 100-degree weather and there's already, as someone mentioned in chat, like, disagreement about wanting to wear masks because of the cultural issues that have happened during COVID, you're going to have to build a Swiss cheese model that's multiple things. And environmental controls, I think, play an important role in that. And beyond that, I mean, there's been a lot of conversation about how we do more sustainable both farming as well as handling of animals and other aspects. Remember, similar situations came up with COVID when meat packing a long time ago, if you think back to your memory, meat packing, factory workers who were infected in closed spaces. We really got to think about occupational risks from these types of viruses and what can we alter in that workspace that doesn't have a big impact on the flow of food, on the growth of, on the management of food, but makes the practices safer for farmers or dairy workers or poultry workers.
Yeah.
Now,
So
Jen,
go ahead, Rick.
Go
ahead. Yeah.
And I think I may have drifted a little bit from your initial question about that's post-exposure prophylaxis you use antivirals and such. To me, it's a reactive approach. What we're learning already is that even if you look at the animals, some of them are very symptomatic, some are mildly symptomatic, or some are asymptomatic. And we saw that with COVID, but we know that with influenza as well. So if we're only providing post-exposure prophylactic to those who have symptoms, we're going to miss a lot of people who are exposed, who might be infected even, and be asymptomatic. And what's the challenge there is that gives a virus an opportunity to adapt and mutate in those people and transmit to others. We also know that with our current antiviral drugs, they're most effective if they are used within the first 24 to 48 hours of symptoms. So, if we wait until we see these symptoms, wait until we see this exposure and things, we could be too late by the time we provide an antiviral. We could be too late to have as much of an impact or significant benefit in those people that we want to treat. And so we want to think about these different nuances. It's not just about having a drug and using a drug when someone's been infected. It really is about the proactive approach. It's about getting in front of an outbreak, and it's about providing the best protection for those people who are at the highest risk. And right now, those are our farmers.
Yeah, that just is raise the question of what is the ultimate goal of our response to the current H5N1 outbreak in the United States, right? I've been asked by reporters in the past about, can we eradicate H5N1? Well, we can't, because the virus, as you know, there's tons of avian influenza spillovers. It's just the way the world has changed right now, right? So we can't eradicate because it's in 40-something mammals. But we can, we can try to control its spread and actually potentially eradicate it in domestic animals and in humans, those animals closest to humans, because we know there's been one main spillover from birds into animals. It's not like maybe it will start happening more commonly as it spreads more, but at least we can focus on controlling it in spaces where they will come more and more into contact with humans. If that itself is a goal, and of course, avoiding human illness and particularly more severe human illness has got to be the goal, I think, from my perspective.
So we've been talking mostly about protecting farm workers, which is the topic of the conversation today, but the previous question about post-exposure prophylaxis, and then this point you're making about controlling the spread of infection on farms and in domesticated animals that have, the most contact with humans. What we haven't talked about is testing in animals on those farms. And from my perspective, I'm really worried that is really insufficient for some of these goals that we've set out. So if we want to rely heavily on post-exposure prophylaxis as a means of protecting farm workers, which is, we think you been exposed, you might already be infected. Here's a medicine to help you with that. I mean, that really requires having much better surveillance on farms in order to understand who is being exposed. Similarly, if the goal is to control the spread of this virus in domesticated animals, that also requires better testing, and that's also not helping. And I think the earlier question that you sort of answered in your conversation about PPE and multiple approaches, absolutely. But we know that the poultry workers who were infected this summer were culling birds that were known to be infected with H5N1, likely not using personal protective equipment, in part because this summer was really extraordinarily hot. So it is a very difficult circumstances to think about some of these interventions operationally speaking. And that's why I think we need multiple. And that's why, for me personally, that's why I keep thinking of vaccine, is that insurance, should all those other interventions fail for a variety of other reasons. There is a ton of questions in the chat, and we've been addressing some of them, but I do know that some people are also sort of thinking ahead to pandemic scenarios and like how quickly we would be able to access vaccines. There's lots of questions about what do we know about how it's spreading. Maybe just kind of let you each answer any one of those, just so we can kind of start ticking off some of the many questions that we have amassed so far.
Jennifer, I can take one that's talking about the U.S. versus the globe.
Yeah.
World. I mean, yes, I mean, a lot of what I describe in terms of our stockpile and our response capability for the U.S. are based on the conversation today is the people at greatest risk and on the farms in the U.S. where the virus is. But we do know that if this were to become a pandemic, it would be around the world faster than a blink of an eye. I mean, there are a number of scenarios and models that have shown us how quickly an airborne avian influenza virus pandemic can spread around the globe. And we know that there are very limited supplies and capabilities to make new supplies of vaccines and therapeutics and diagnostics and even PPE. So, you know, part of what I alluded to earlier is the capabilities we have to respond to a pandemic were built around some of these tools in the 1940s and 50s and 60s. And they haven't really been modernized or updated much since then. They are not equipped for a global response, let alone an equitable global response. And that is why it's so important that we also, while we make sure we have the foundation firm and what we do have, the tools we have, make sure that we are pressure testing them, make sure we're warm basing them, make sure we're expanding those capabilities around the world. And we have invested a lot over the years of expanding flu vaccine manufacturing capacity around the world in maybe 15 and 20 different countries now. So it's not just 4 or 5 that have that capability. But the egg-based influenza vaccine manufacturing technology is not equipped for a 21st century pandemic of avian flu. And so we have to be honest with ourselves and accelerate the development of new vaccine technologies that can be scaled faster. They can be produced regionally around the world, so we don't have pockets of the world that are last in line, like we've always seen with pandemic response, that we have technologies that can be used globally in different regions to make vaccines regionally to improve that access in an equitable way. But we have to find technologies that are able to surge faster. And eggs aren't. If I think about an avian influenza pandemic that kills chickens, so if we kill the chickens, we kill the eggs. We don't have eggs, we don't have vaccines. So we can't put all of our eggs in one basket when it comes to an avian influenza pandemic. And we need to accelerate the investment in developing faster technologies that are not reliant on eggs or cells, that can surge faster, and they might even have to adapt faster to changing virus parameters. We know influenza viruses mutate so quickly. And so if we start vaccinating and then see with an influenza vaccine, and we see that virus change, which we expect it will once it starts infecting people more efficiently and going person to person, Well, you have to have vaccine technologies that can keep up with the pace of that viral change. If not, get in front of it. And so with the modern tools that we have today, we can look at parameters around the virus, around our immune system, around the tools we use to make vaccines. And I would hope with the right investment and collaboration, we could use technologies that can respond faster, maybe get in front and prevent the spread of that virus, and make sure that those tools are shareable to manufacturers around the world so they can produce them locally and not rely on 1 or 2 or 3 high-income countries for their charity, which we know, sadly, often comes too late.
I can't agree with Rick more than that, because clearly my job during my time at the White House was partly about vaccine sharing during the COVID-19 pandemic. And I'll be the first to say that we gotta be faster. The US was, one of the biggest donors of vaccines, but donation is different than actually co-creation and sharing. Can I answer a couple of questions that are related? Yeah. The question about the Tamiflu resistance and the question about testing for animals that are more proximal to humans related in this way. Are we worried about resistance? Absolutely. You might have seen that there was a study that showed a dolphin had findings where the virus, the H5N1 virus, was actually much, much more resistant to existing antivirals. And so, of course, a concern would be selection of those viral subsets during an infection that could breed resistance. And that could be the case if a patient does not get enough of an antiviral, or there's a sporadic mutation. So if you underdose an antiviral and the virus continues to adapt to it in a human, for example, you could cause a resistance. You could help those colonies of the virus potentially grow that are resistant. So absolutely. So how is that tied to testing? Well, we won't know if that happens unless we have phylogenetic testing and genomic sequencing that we know was so important during COVID-19 as well. And that's why the testing infrastructure, to what you said, Jen, is so critical, because understanding not just the diagnostic testing, the clinical diagnostic testing, but then being able to connect it to the rest of that sequencing to be able to pick up resistance patterns in the virus is going to be so critical. And that ties to the testing of a wider net of animals, right? Some of this falls under whose job is it? Is it EPA? Is it USDA? Is it CDC? Who do rats fall under the jurisdiction of, right? Who funds that work that looks at rats and mosquitoes and other aspects?
I think Naheed froze.
Wait, she froze. Can I pick up her?
Yeah, please do.
Please do. Come back in then, because there's probably few things more concerning than the vulnerability of our limited types of antiviral drugs for influenza. We really only have 2 different kinds of influenza antiviral drugs now. And we've seen with the neuraminidase inhibitors, particularly with also Tamivir or Tamiflu, as you know it, we've seen how fast the virus can change and evolve to become resistant to that antiviral drug. If our primary stockpiled antiviral drug is just also Tamivir or Tamiflu, then we will likely have a very short limited usage period for that drug before we need to switch to something else. And it's going to be critical to have another option. We have a number of publications showing from people who have been infected with H5N1 in the past, within a day or 2, the influenza virus has evolved within a person to become resistant to Tamiflu. We saw in the 2009 H1N1 pandemic, it just took a month or 2, very short time frame within the spread of that virus before countries were already reporting the existence of influenza viruses that were resistant to those drugs. We cannot rely on a single class of drug, such as a Tamiflu. We have another class of drug that targets another part of the viral makeup called Xofluza. That's a way to diversify, but even that has the potential for the virus to mutate and become resistant. So we can't just rely on antivirals that target the virus. One of the big deficiencies we have in our treatment options are treatments that will target the immune response, a hyperinflammatory immune response sometimes that we make when we're infected with influenza viruses. We need host-targeted therapies that will manage our cytokine storm or inflammation or fever, all those things that can often cause more damage than the virus itself. There are so many areas of development that we are needing to accelerate and invest in for therapeutic options for influenza. And my great concern is we have such an abundance of one antiviral drug. We know its vulnerabilities, we know its challenges and need for early use. We don't have home tests. We need home tests that tell a person when they're infected. We need within that 24-hour window to go from that test to treatment. So therefore, we have some work to do about access to home test or point of care test where a person who is positive can immediately get access to antiviral drugs. And then, of course, monitoring for that resistance and the ability to switch quickly when we see resistance emerging. Those are all tools
I'm glad you brought that up because we didn't quite get into this in terms of the farm workers. Obviously, I think that scenario for broader pandemic spread is a very relevant one. But even in terms of farm workers, making sure that tests are available, not just in the context of where someone works, making sure that they can get tested. And Nahid, you had talked about this in terms of that, availability is not the same as accessibility. Making sure that people can get tested in a variety of settings, including potentially in the kind of privacy of their own home so that they can know when they would benefit from having treatment. But because you both brought up resistance and Nahid before you froze, and now I'm glad you're back. And Rick, you talked about in the context of the antivirals. There is a question here that I do want to queue up because this comes up a lot, which is the question about whether using the vaccines will force mutations and resistance. This is one of those common lines that get circulated. So I can read the direct question to you if you want. It says, will these vaccines have an impact on accelerated mutations? Can you just comment on that? Either one of you.
In my opinion, and Nahid, please correct me if you think differently, I don't think they will. Number one, it's going to provide a level of protection in the people who are vaccinated. They're not hopefully getting exposed to this virus. And therefore, if you're vaccinated, you're not getting exposed to the virus, so certainly there's no interaction between that immune response and the virus itself. I do know what you're implying is the opportunity sometimes for your immune response to push forward at least the evolution of a virus. And I think we do see that sometimes with seasonal influenza and seasonal influenza vaccines, where we have large populations of people vaccinated, and we have this constant evolution and presence of seasonal influenza viruses. I think initially this protective layer that we're talking about with pandemic vaccines, or H5N1 pre-pandemic vaccines, is more about providing a layer of protection for when those viruses do start spilling over and infecting more people. And it's a different approach than probably a mass vaccination campaign in the presence of a widespread virus. But
yeah, I was going to say, I mean, there's already an evolutionary pressure because so many more humans and mammals and animals have gotten infected. It's almost like a natural experiment of pass-through right here that we're going through. So we can keep our fingers crossed the virus is not evolving towards something that is worrisome to all of us. I think it's sort of that, yes, that risk, of course, theoretically exists, and again, to Rick's point, like we're not talking about a mass vaccination, we're talking about an individual benefit for a smaller group of people, particularly if it's more targeted and particularly if it's under, but under sort of research and study. But that brings up a good point of like, at some point, God forbid, we won't have to, but we may have to. And if we do, what's our sort of like surveillance to make sure the virus is not changing? Are we going to keep the funding alive that was put during COVID-19 to ensure the same amount of genomic surveillance happens to ensure the virus is not evolving? There is in addition to the things, Rick, you talked about, sorry, I fell off, so you must have mentioned this, but I think there is so much need for more antivirals, right? The antivirals that are newer development. So we have them in the pipeline, and the NIH's antiviral program for pandemic pathogens is an important pipeline, but we need to bring some of those forward into further development. The other thing I was going to say is, this was one of the things that I'd worked on while I was in the White House, the work around Project NextGen, which is on coronavirus next-gen vaccines. And some of the work there was actually not just for coronaviruses, but on some of these elements around host response around more conserved areas of respiratory pathogens. We do need to keep working on those aspects to avoid exactly the scenario where you target places that are not as prone to evolutionary pressure in viruses, which will yield to us more dependable countermeasures.
So we have
Jen,
just
can I,
before
before you
sure.
go to close thing real fast, because I hear from a lot of farm workers and their families right now. And I hear one side, I hear government officials saying we have all the tests we need and the tests are readily available and et cetera. And the other side, I hear from farm families saying we can't find tests. We can't get a test. We don't want to be part of a government managed testing program. Why can't we, if we want to get a test somewhere in our clinic or our vet, if it's an animal, yet we just get a test? And, I'm concerned that we do have tests, but they're not really available. People don't know how to access them. And when they really need them, remember, we're in the short window. When they think they need a test, they don't have time to call 20 people and wait a week or two and get some official guidance. They need to walk into their doctor's office and get a test. And they shouldn't be riddled with a series of questions. Well, how close have you been to a sick animal? Or how far do you live away from a farm? Or so. It's like, you want to test, you think you're at risk, you think your family has these symptoms. Here's a test. They're not expensive. They should be free for the people who want and need them. It would provide people that level of comfort and assuage some of their concern. And it would actually give the government and other state at the local level a lot of information about the level of concern in the community and about the level of virus perhaps in the community. But when I hear some say we have all the tests we need and they're available, and I hear a lot of people from the rural communities across our country saying, I can't find one. Who do I call? I have symptoms and I can't find a test. Or I think we were exposed 2 months ago. Where can I get my antibody titers drawn? We should have simple answers for those questions, and it should be easy to get to, and it should be free.
Can I just make one comment? Because Rick made a very important point we cannot miss, which was there are folks, we should depend on our governments, our federal governments, and our state governments. They have the primary responsibility, right, for public health response in these scenarios. I think that though in scenarios like this where you might have distrust of the government, right? How can our public health partners at the state and federal level, as well as all of us who are part of the bigger preparedness community, how do we engage non-likely partners who can be funded, supported to create that access to these communities so it's not a direct throughway to a state or a federal government system? So, farmers feel a bit more comfortable is going to be important as well. But also how, as we as a larger community can respond to this in a way that's beyond just the government aspects that we've been talking about.
Thank you both. I'm just looking over the remaining questions. There was a lot that we didn't get to. There were a lot of questions about science, about how this is transmitting and whether, prior infection with a N1 influenza will confer protection against H5N1. We know that there was a pandemic in 2009 with an H1N1, and that's a hypothesis for potentially why we may be seeing milder infections. I think my general reaction to a lot of these science questions is we just don't know. We just don't know. And we have a lot of things that we still have to learn about this virus, some of which we can see signals of in earlier H5N1 data, but some of it we just can't in the context of this particular outbreak that we're seeing on farms. So thanks to everyone for those questions. And I would say a lot of them we just simply don't know the answer to. But I will, just before I close, I think point out that we're talking about one virus today, but we're having this conversation on the same week that the World Health Organization declared that the global situation with Mpox virus represents a public health emergency of international concern. I am also this week still getting lots of questions about the tremendous amount of COVID that's going around. So it's a bit just staggering how many different viruses and threats that we're talking about at the same time. And while we can have this very specific conversation about the very specific science on this one virus, just recognize that this is a recurring situation where we have these new hazards popping up all over again. And many of these conversations, yes, sure, we're talking about particular vaccines and particular treatments. The questions about what do we have and is it enough? And do we have the systems in place? And can we reach the people we need to reach? Extends to all of these crises. So we are at time. And so with that, I just want to really thank you both, Rick and Naheed, for your time and for sharing your insights and really for all of the tireless work you do to educate and to improve our preparedness for these events. I want to also thank everyone who joined us today and submitted your excellent questions. Really extraordinary turnout. Really appreciate everyone's attention. I'd like to thank my team at the Pandemic Center who helped put this event together: Bentley Holt, Michael Mitchell, Leah Lovegren, Amanda Kogan, Carly Gaska, Andrea Uleg, and Ann Wang. And finally, if you would like to share this event with anyone who was unable to attend, the recording will be posted on the events page of our website next week. I see the sign is up so you can see where to find that. And you can also find recordings of all our previous webinars there. Please also follow us on our social media accounts, and the handles are there too. This is a recurring series, and please reach out to us if you have any questions or suggestions for future ones. So until our next session, thank you all. We're adjourned. Be safe, be happy, and stay engaged.
Thank you for having us, Jen.
Thanks.
Thank you.